Well, Dave, it's a pleasure to talk with you.
Same here.
Let's start with a question. So, what does health equity mean to you, and why is it important?
Health equity is a term we often use in the United States, the term health disparities as well, or health inequities as well. So there are lots of different terms used. But basically, they describe differences in health that are unfair and unjust. There are some differences in health that occur, that naturally occur, that would be expected to occur. But it's those differences that are unacceptable because they are unfair and unjust. And I think it's important to me because there are such large and pervasive disparities in health in the United States by place, by socioeconomic status, income, education, occupational status, and by race and ethnicity. And I think it's unacceptable in a country, given the values that we have of providing equal opportunity for all.
Can you personalize that for a minute, a story or an episode or something that gives us a sense of why this hits home?
It hits home for me for many reasons. One is I have spent the better part of 2 decades studying as a researcher these issues. But there are many personal experiences that I have had that brings it home in a very real way. I remember many years ago attending the funeral of a good college friend of mine whose wife, an African-American woman, had just died of breast cancer. And she was 33 years old. And in America, breast cancer typically for most Americans is a postmenopausal condition. And her experience just typifies that of so many African Americans who get a very aggressive type of breast cancer at a very young age. So in the United States, we have this interesting pattern where white women have a higher incidence, or more new cases, a higher rate of new cases of breast cancer every year. But under age 40, African Americans have a higher incidence of breast cancer, reflecting the fact that they are much more likely to get the disease when young. I'll tell you a second experience. One has to do with my own mother, who was receiving treatment, and because of poor treatment in a healthcare facility, had a stroke. They had failed. She was receiving her medication through a patch, and a nurse had failed to change the patch. And so she had gone days without her medication and ended up having a stroke, which left her with significant disabilities. So that was another example, because there's research suggests that it's not just her, but minorities receive poorer quality care and less intensive care.
Sorry to hear about your experience.
Well, I don't want to make it a personal thing, although the personal experiences do bring it home, but it does reflect that this is not an isolated case. If we look at national data for the United States, it suggests that just in terms of black-white death rates, that 265 black people die every day in America who would not die if there were no racial disparities in mortality in the U.S.
265 people a day.
265 black people die prematurely every day who would not die if there were no racial inequities in health.
So, okay, I mean, some of the data are new, but not all of them. We've known about disparities and inequity for a long time. I can remember it from years of my training, decades ago. Why aren't we there yet? What's been in the way?
I would want to first say that we have made progress, and we certainly want to celebrate the progress that has been made. So, for example, the life expectancy gap between blacks and whites was 8 years in 1950. It's 4 years today. So we've cut it in half. That is definitely progress.
This is for a child born today. The life expectancy gap is shortened by 4 years.
It is shortened, right. So, and that is progress, and we want to celebrate the progress that we've made. On the other hand, a 4-year gap is in fact considerable, and if we look at the average rate at which life expectancy increases, it will take us more than 25 years to close that gap, if we froze the life expectancy of whites and had the life expectancy of blacks increase at the average at which life expectancy has increased over the last decade. So 4 years is in fact a considerable gap. Why? I would say there are two big reasons in my mind. One is there is not broad-based awareness in the general population and among some policymakers of the magnitude and extent of disparities in health or inequities in health. So that's one reason, is the lack of awareness. If we don't know that a problem exists, we're certainly not going to mobilize to address it. So that's one. The second reason is maybe more troubling and more difficult to deal with. The second reason is there is the absence of political will. I think to make the investments that need to be made in order to make progress. And by that I mean that just for many people who are aware of the problem, there isn't an emotional connection to it. There isn't a feeling that this is unacceptable and that we really have to mobilize to do something about it. I'll give you a statement that was made by W.E.B. Du Bois in 1899. This is a long time ago. He wrote a book called The Philadelphia Negro. In that book, he had a chapter on the health of blacks in Philadelphia in the late 1890s. And he said one of the most difficult social problems in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And Du Bois went on to say, there have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference. So it's that peculiar indifference, the absence of will to address what is in some ways an unprecedented national tragedy, I think is part of the problem. And so we need to think of ways in which we can tell the story. And I think narrative is important, so I use the word story carefully and deliberately. We need to tell the story of health equity in a way that connects with the American population, because I think we have a very compassionate and generous population, but we need to tell the story in a way that they can connect with and then be mobilized to address it.
Is this racism? Is this racism in society and in healthcare, or is...
Racism is a significant contributor, I think, to it in multiple ways. Some ways in which the racism is obvious to individuals, and many ways in which the racism is not obvious to individuals. So let me give a couple examples. Back in around 2000, I was invited by the Institute of Medicine to serve on a committee that was going to address the question, what happens when blacks and other minorities get into healthcare contexts in the United States? Does their race or ethnicity make a difference in terms of the medical care they received? The report by the IOM released in 2003, it was called Unequal Treatment. And what it documented, that was across virtually every class of medical procedures, from the most simple to the most complex, blacks and other minorities receive poorer quality care and less intensive care. We were not addressing issues of access. The question was, given access to care, is there a difference in the quality of care received? And we found absolutely there was a striking difference. We did not believe, the Institute of Medicine Committee did not believe, I do not now believe, that the American physicians wake up in the morning and say, how am I going to get my minority patients today? I truly think that most medical doctors go to work, and other healthcare providers, and try to do their best for their patients. If that's true, then there's a conundrum here. How is it possible with people with good intentions seeking to do their best can nonetheless, at the aggregate level, create a pattern of care that is so discriminatory? Our answer was implicit bias. It's also called unconscious or unthinking discrimination. And when the IOM concluded that that was a contributor in 2003, there was a lot of circumstantial evidence. Today, the evidence is even stronger than it was then, that implicit bias exists among physicians and other healthcare providers, and that implicit bias affects the quality of care they provide to minority patients.
Can you help us understand a little better this implicit bias view? So I'm a doctor, a patient comes in, white, African American. What happens in my conscious or unconscious or in the interaction that becomes a generator of the kind of inequity you're talking about?
It's a great question. What the research shows is that most of us, and this is about not white people, this is about human beings, most of us think that we are driven by our conscious cognitive conditions. In fact, a lot of what we do occurs at a level beyond our conscious awareness, and is importantly driven by ideas and narratives and stereotypes that have been deeply embedded in us as part of the culture or the society in which we were raised. There's a lot of research that indicates that in American culture, African Americans, for example, are presented as lazy and dangerous and violent. Those are negative characteristics. Healthcare providers are part of the larger society. Research using the implicit association test, which is one test that tries to get at these unconscious implicit biases, finds that over 70% of all Americans have an anti-black bias. And the number for physicians is also over 70% because they are part of the larger society, we are products of the culture. So it does not reflect then the behavior of bad people. It reflects the behavior of normal Americans who are reflecting the biases and the messages about race that they have received. Importantly, what the research shows is that when we have this negative implicit bias, this negative stereotype, even though we personally are committed to egalitarian principles, without our conscious awareness, when we meet someone who fits that stereotype, we will treat them differently and honestly will be unaware that we did it because there was no intent on our part. And that's why it's called unconscious, unthinking discrimination. It's implicit, it's not explicit. You're not looking at that person and saying, I'm going to discriminate against them. In fact, if I asked you if you did, you'd say I didn't because there was truly no intent. So it's something that we need to raise awareness levels of. There are a number of strategies that can be used to help clinicians and all persons become aware of this tendency that we have. The other point I would say, this is not just about race. Race is very salient. When we meet someone in American society, the research shows, we first put them into social boxes based on age, gender, and race. So race is one of the three big factors, social factors that we focus on. But it is a more general phenomenon. If I have implicit biases or negative stereotypes about fat people, about gay people, about old people, about women, those same processes occur. So I like to tell my students that I am a prejudiced person because I am a normal human being. And if we are normal human beings, we are prejudiced because whatever society we were raised in has raised us with negative beliefs about some outgroup. Every society has in-groups and out-groups. So the question just becomes who belongs to an outgroup in the society in which you were raised, which means might be implicit in my own mind.
But you say, is there a remedy if I'm a physician or a nurse and I believe what you're telling me, which is I don't believe I'm racist or acting in such a way, but there are unconscious biases at work. Can I unlearn them? Can I work my way out of it? And if so, how?
There are a number of strategies that have been shown to be effective. One of the basic override, well, I would say two things. The first thing is to realize that could be me. The typical healthcare provider, I had many talks to medical, nursing, and other health professional groups after the Institute of Medicine report came out. And the typical healthcare provider in the United States would say, I would never do that. I would never provide less pain medication to a black patient than a white patient. Whereas the evidence is clear that black patients get less pain medication. with similar levels of conditions. So the first thing is to realize that could be me, and that people who have implicit biases are not bad people. They are just reflecting the culture and the beliefs that they were raised with. So that's the first point. The second big principle is the challenge of focusing on what we call individuation versus categorization. What is normal for human beings as we process information is to put things into categories. So I see you, and I don't see you as a unique individual, Don Berwick, but I see you as a middle-aged white male. I've put you in a category, and in my mind, there are lots of associations that comes with middle-aged white male. So it's how do you look at a person, at your patient, at your client, and see that person as an individual, and try to understand the individual context of that person, as opposed to instantly seeing them, which is natural, because that's how we deal with the complex cognitive information we have to manage every day. We put things into categories. It simplifies life. It helps us to navigate our social world. So it's normal for us to do that. So that's one general principle. There are a range of other strategies that have been shown to be effective. One is trying to put yourself in the shoes of the other. So you have a patient who was an elderly black male, and if you stop and wonder what his life was like, and what was it like for him to grow up in this society, and what are the things he encountered. So the extent to which you tried to walk a mile in someone else's shoes, that is another strategy that has been shown to be effective. There's also a strategy that's called counter-stereotyping, which means you think that all women are weak. Well, could you sit back some days and just imagine what a strong woman would look like? Mm-hmm. And imagine that women could be strong. So those are a number, but they're broad range of psychological strategies that have been shown in very careful laboratory experiments to minimize the occurrence of it. I would say two things. One is processes of implicit bias are more likely to occur when someone is working on the time pressure, so you don't have time to think. You just default to your social categorization processes. It's also more likely to occur when you're dealing with complex cognitive information. In fact, researchers point out that many of the features of a typical encounter between a patient and a healthcare provider, the ingredients within that encounter are some of the very factors that social psychological studies show maximize the processes of implicit biases operating.
I'll guess that fear can play a role in it.
Yes,
when you're
fear,
afraid.
anxiety also play a role, absolutely. Yeah. Fear, anxiety also play a role.
Well, one more question. So let's go back to the 4-year gap between the racial gap in life expectancy that remains and is unconscionable. Can we close that with health care? Or is or not?
That's a good question. So healthcare clearly has a part to play, and ensuring that every patient gets high quality care would be a step in that direction, because there are racial, ethnic disparities not only in the onset of disease and the prevalence of disease, but in the course of the disease. The severity and course is worse, and part of the poorer prognosis and the more difficult severity of disease for many minorities, it reflects the fact that they don't get as high quality care. So quality care is important. Most estimates suggest, though, that medical care alone will not solve the problem. We have to look at all of the factors that drive health. The fact that medical care is important in terms of restoring us to good health once we get sick. But what drives health, what makes us healthy in the first place, has a lot to do with the opportunities to be healthy in the places where most Americans spend time, in our homes, in our workplaces, in our schools, in our neighborhoods. And so where we live, learn, work, play, and worship, and the opportunities to be healthy in those places have a lot to do with health. So health strategies, would include things like ensuring that every child has a life where they can grow up and thrive and be not only ready for school, but a life free of early childhood adversity and stress, which could include things like chronic poverty, for example, stressors that have long-term negative health consequences. There is a very strong relationship in the United States and elsewhere in the world between education and health. So ensuring good quality academic success ensures better socioeconomic success, which is powerfully linked to health. Looking at the opportunities to be healthy in neighborhoods. In some neighborhoods, it's not easy to find a safe place to exercise. There isn't access to fresh fruits and vegetables. So again, creating a culture of good health where the healthy choice becomes the easy choice, where people work and where people live, are all factors that can play a role in improving the quality of health. And racism has played a role in creating neighborhoods that are unequal in access to resources and so on. So that's another distal mechanism in which racism affects health.
I can't help asking this, so I give you a lamp with a genie installed, and you get 3 wishes that would really close this health equity gap. And you know what? You choose. Answer it either from the viewpoint of healthcare delivery. You run a big hospital or a large system. What would you wish for that system? Or from larger social perspective, what would be the biggest leverage we could get?
It's a good question. I served on the commission that actually addressed that question.
I know.
And reported that the single biggest thing we could do in the United States is to ensure healthy development of every child. And investing in early childhood, particularly birth through 3. We tend to, when we even think about early childhood, we tend to think of ages 4 and 5. And the processes that shape childhood development and affect health begins earlier. So I think that is certainly one big area, but it's not the only one. I would also say that I think we need to put more health into healthcare. What do I mean by that? Many patients who come into a healthcare context are coming with a range of social challenges that they face. And if all we do is provide them healthcare and not address the problems that made them sick in the first place, and send them back to the same environments that made them sick in the first place, we have delivered good health care, but we haven't had a long-term positive impact. So there are models and there are multiple conversations, multiple examples in the United States of programs that are, as part of the healthcare encounter, linking a client, linking a patient, not only to good medical care, but to social services that might help them address some of the challenges they face. And we know that if we do that, we might keep some of those people from coming back into the healthcare system, back into the emergency room within 30 days, if we can in fact link them with the social service. I think that's one other strategy. And the third thing I would say is strengthening education, which would prepare individuals for successful employment and career advancement is important. Maslow, many years ago, taught us about a hierarchy of needs. Mm-hmm. And if people's basic needs are not met, they don't worry about the higher order needs. And many of the things that we want individuals to do, to get regular exercise, to not smoke cigarettes. If tobacco is the crutch that helps people make it through the day, and some of my own work and the work of others have shown that smokers have higher levels of stress than psychosocial stressors than non-smokers, and that if you intervene on the stress or underlying depression that they face, you enable them to quit at higher rates.
Really?
Yes. So again, trying to take in a big picture and trying to address some of the social challenges that individuals face will put them in a position when they can act to make steps to improve their health. Well, Dawn, could you tell me why health equity is important to you and what role you see health equity playing in the context of larger improvements in healthcare?
Health equity is important to me because it's a piece of the larger problem of social justice. I think we have become in the U.S. and many other countries an unjust society, failing to attend to the needs of people who start off with or fall into positions of great disadvantage. And I just don't like that. I don't know why, but maybe because I grew up in a small town where we kind of took care of each other. But no, we can't. I don't want our society to be one in which we turn away. And to me, health equity it's a symptom of that larger, crucial issue of the fabric of communities in our society.
Sure.
I guess the other reason is I'm a doctor. I don't practice anymore, but when I did, about maybe half of my patients were under conditions of enormous stress on Medicaid, in poor families, in broken homes, and I could see the challenge, and frankly, I felt helpless a lot. That the kid with asthma who came back and back and back because there was no heat in their home, or because we couldn't get the home cleaned,
sure.
or the child failing at school who becomes depressed because their self-image is hurt, and then the vicious cycle begins: a poorer sense of self, less effort, more failure, and you could see the cycle penetrated. I could give pills, or I could treat fevers, but that wasn't creating healthy futures, and so it meant a lot to me. There's a case a kid I've written about quite a bit. It's a real story. Some patients stick with you, and
sure.
This young guy, he was a 14-year-old when I met him, was in deep trouble. He was drug addicted. He had,
at 14.
At 14, he had his first gun when he was 5.
Wow.
And he was in and out of trouble, but then he got leukemia. He got acute lymphoblastic leukemia as a 14-year-old black child, which, as you may know, is an extremely difficult disease. For some reason, acute lymphoblastic leukemia, which you can cure easily in a 5-year-old white, it behaves really badly in a 14-year-old black. But we went to the mat. This kid got everything. We got him a bone marrow transplant, sophisticated chemotherapy, walked him through great difficulties, and he was cured. His leukemia went away at 17. There was no trace. And we remained in close touch until he died at age, I think he was 29, on the streets. He basically fell apart and ended up having a seizure due to drug abuse, and he cured leukemia and killed by poverty.
Yes.
Killed by disparity. I've often said he would not have said that. This kid would never ever blame anyone but himself. It was really interesting. He internalized this, but I say that, and I can't forget that kid.
That is a really powerful story. What advice would you give to people who in their own healthcare system are thinking they would love to start a conversation about health equity and about racial bias in healthcare? What advice would you give them as to how to go about this?
Well, I'm not sure. I mean, maybe call you, but I think a good rule, IHI's rule in general, is you start with yourself. You don't ask other people to do something you're not doing for yourself. And I think this point you've made so eloquently about becoming self-aware, especially about the unconscious and innate biases that are there that we don't even realize. And I think that introspection, I think it's on the critical path. So if I were head of a large health system, I would say we're going to look first at ourselves and understand this. And I think there are places and people that can help do that, but I think awareness matters, and I think that matters. Another that's very important to me, that is part of the principles of quality, is the voice of the customer, the voice of the person you're trying to help. And I personally think helping people who are in positions harmed by these latent inequities need to speak and be heard, and not pro forma, not in a focus group, not in a survey, not one at a time, but in mass. And I think if that dialogue is real, and it's starting, by the way, with the board of trustees.
Absolutely.
This belongs in the governance system,
absolutely.
where the inquiry is really
Yes.
authentic.
Yeah.
My friend and mentor Paul Batalden once drew for me a graph of the sequence of events for real change and improvement.
Right.
And the first box he drew was leadership, curiosity, and I believe that. And I think if we want to reverse this injustice, we need leaders to become, I say, authentically
Yes,
curious.
yes.
We're not talking about ticking
Yeah.
boxes here.
Mhm.
It's a real, maybe it's a personal transformation I'm after. That's a big ask.
Yes.
That's a big ask because people
Yes.
are very busy. But
Yes.
I'm a scientist too, and I think then the question, if one is aware and one does care and one has heard, the legitimate question is, well, what might work? What could help here? And I
Yeah.
think we need to turn to science. I think
Yes.
we need to understand what's been shown,
Yes.
what might work here,
Yeah.
and put it to use.
You give one good example of improvement science and a lesson you learned from it. Is there another lesson, any final lesson you might want to give us from improvement science, how it might help address health inequities?
Learn from action. We've been taught, in Western society, and we've been taught, you think and think and think and think and then act. No. You think maybe, then you act, because the action produces knowledge on the basis of which improvement can occur. And I really think getting into change is important. That could be one patient, one person at a time, one
yeah.
person at a time.
Yeah.
Discover an episode of racism at work,
Mm-hmm.
an episode of inequity. Fix that one.
Yeah.
Go at it and say, what could we do with this, with this particular person, and learn from that. So I'd say moving quickly as we can to deeds, which then become informative for the future, is much more important than the next strategy meeting.
Yeah. No, that is great. And I think one of the good things is that there is such a mushrooming body of research on this very topic that is in fact pointing to steps that can be taken. So there's many people are not aware of it, but there is an available science that may not answer every question, but provides the foundation for moving forward in very concrete ways.
I hope so. That will raise the question of measurement and feedback
Yes,
and knowledge.
absolutely.
You have to learn as you go. And
Absolutely.
I guess you would know more than me as to whether we could have or do have the ways, once we do want
Yes.
to have this as a goal, to actually monitor the progress as we make it.
Yes. I sometimes, when I talk about it, says we have a divine solution. And divine, D-E-V-I-N-E, is the name of a psychologist at the University of Wisconsin-Madison who has come up with a model of a number of the strategies, some of which I talked about earlier, that actually work to reduce unconscious bias. And she has shown that she can take non-white individuals and from the community and get them motivated, one, and two, utilizing multiple strategies that followed over time is successful in reducing both explicit and implicit bias.
That's great.
And so there's evidence that and strategies of what can be done.
I've become a fan of Helen Reese's work at Harvard. Helen's interested in, can you teach empathy? Because you were
Yes.
talking
Yes,
earlier
yes.
about walking in someone's shoes. The answer is yes, you
Yes,
can.
yes.
So we're not without some
Exactly.
methods and approaches to try out.
We know
once
where to
have the
start.
will.
That's
Yeah.
right.